Well, good afternoon and welcome here. Thank you all for coming, and I know it's been a busy day and this has been a spectacular meeting. I'm Jonathan Yar. I'll be presenting. I've been in anesthesiology faculty for more than 30 years now, and my pain portfolio is pretty extensive, including studying IV acetaminophen, doing the pivotal trials as lead investigator, all the way up to IV meloxicam, which is what I'm going to be talking about today. So again, thank you for coming. First, I must say, happy Veterans Day, and for all of those who have served or are serving now, we certainly thank you for your service. My son is a commissioned officer in the Army down in Fort Bliss in El Paso, and he is probably going to be sent off to Korea to make sure that the demilitarized zone is safe, and we wish him well, obviously. The other nice part of this story is that I met Dr. Caillet, the real inspiration for this whole society, as well as multimodal pain management, as well as being a spectacular surgeon and colleague. Met him about 30 years ago, and we were sort of sitting and kind of talking about all of these things that are now coming to fruition. So this is very exciting for me to be here and actually present to you and really help sort of put all the pieces together. Another part of the puzzle that I think I might have mentioned to a couple of you here today is that my dad's a surgeon, a lot of colorectal surgery. My mom's was an anesthesiologist. So I think I got perioperative medicine and ERAS in my bones or my blood or whatever you get it in, my genes, I guess, even before I could walk or talk or think. So it's sort of been there. And this collaboration between surgeons and anesthesiologists and nurses and the pharmacy team and all these others is so crucial. And it's been so lacking in really good care because we've all been sort of doing our own thing and not communicating. And so much of this meeting has really been breaking those barriers and facilitating these interactions, which are crucial. Because if we don't work together to take good care of a patient, how on earth are we going to do that if we're all doing our own thing sort of independently without any interconnection? So with that as an introduction, I am pleased to be here, and I think I'll get started. The first thing that I wanted to mention is not specifically related to IV meloxicam, which is the topic of the talk today, which I think you'll find that, I'm preaching to the choir. So this is kind of a wonderful lecture for me, but I think there might be some interesting opportunities and adjuncts that have just come along that might even improve our care and hopefully even improve our outcomes, which I think they very likely will. But just the other day, a colleague of mine Dr. Ed Mariano, who is the chair of the American Society of Anesthesiologists Committee on Regional Anesthesia and Pain. He's the president-elect of the California Society of Anesthesiologists, and he is very actively involved in ASRA as well, the American Society of Regional Anesthesia, just came out with new guidelines that are very impressive. And when I spoke with him the other day about my giving the lecture, he said, please put in a good word for us, because these guidelines are so influential, really. It's the new principles for acute perioperative pain management were endorsed by 14 medical societies, and including American Academy of Orthopedic Surgeons, American Academy of ENT, American Association of Neurological Surgeons, oral surgeons, obstetricians, American College of Surgeons, American Hospital Association, AMA, breast surgeons, plastic surgeons, regional anesthesia and pain medicine, American Society, so that as well, urology, and thoracic surgeons. And all of these societies banded together, really, I think almost for the first time, to come up with 7 pillars that I'm going to very quickly go over, because I think they tie everything together, and they actually tie what I'm going to talk about in a minute about IV meloxicam, I think, and kind of bring this all home. That's what this meeting is doing, and I hope that the ERAS Society will consider joining this initiative, because I think everything in this is sort of bread and butter to you. Clinicians should conduct a preoperative evaluation, including assessment of medical and psychological conditions, concomitant medications, history of chronic pain, substance abuse disorder, and previous postoperative treatment regimens and responses to guide the perioperative pain management plan. Clinicians should use a validated pain assessment tool to track responses to postoperative pain treatments and adjust treatment plans accordingly. Clinicians should offer multimodal analgesia or use a variety of analgesic medications and techniques combined with non-pharmacological interventions for the treatment of postoperative pain in patients, in adults. Clinicians should provide patient and family-centered, individually tailored education to the patient and/or responsible caregiver, including information on treatment options for managing postoperative pain, and document the plan and goals for postoperative pain management. Clinicians should provide education to all adults, patients, and primary caregivers on pain management team, including proper storage and disposal of opioids and tapering of analgesics after hospital discharge. Clinicians should adjust the pain management plan based on adequacy of pain relief and presence of adverse events. And finally, clinicians should have access to consultation with pain specialists for patients who have inadequately controlled postoperative pain or are at high risk of inadequately controlled postoperative pain at their facilities. In other words, long-term opioid therapy, history of substance use disorder. So obviously this is just bread and butter to you all, and I hope that you will join that initiative of all of those societies and participate in that, because I think it really summarizes almost exactly what the last lectures said so eloquently. So let's get started here and talk a little bit about IV meloxicam. As I mentioned, I've done a number of studies and published on it, coming out with a chapter in Dr. Ehrman's textbook on acute pain. I'm sad that he's not here. He's co-editing that with Dr. Alan Kay, a dear friend. I, in fact, was faculty here at Tulane many years ago, just up the street, I should say. And so it's wonderful to be here in New Orleans. This is presented on behalf of Botox Bio, and consistent with FDA regulations and guidelines, I am being compensated with an honorarium for this program, and it's part of this satellite symposium and not actually part of the accredited program, but I will say really what I think is very important about the studies and be as science-based as possible. So looking at IV meloxicam, it's the first and only once daily IV analgesic. That's really exciting when you think about it. We don't have any other drugs like that, except maybe methadone, and obviously that brings us down a whole other rabbit hole. But anyway, this drug has up to 24 hours of pain relief. It has demonstrated safety and tolerability, which we'll spend some time on. It is a COX-2 preferential IV NSAID, and we'll spend even a little bit more time on that to show where its positioning is between COX-1 and COX-2, which really tells the story. It's a once daily IV push, very much like ketorolac, an ml bolus that can be injected, so ease of injection is absolutely there. And there is post-approval data on healthcare utilization that I think is quite compelling. It was not part of the FDA submission, but I think really tells the story of where this drug creates enormous value. And so in you and your practices, at whatever point you are in those practices, I think this might be a very, very important adjunct, as many of my surgical colleagues are quite reluctant to use ketorolac due to its bleeding, due to its renal issues, and due to GI. If it's given longer, it can't be used preemptively. And I think that's probably what I hear most in this meeting, that sort of the preemptive use and blocking of pain before it occurs even, especially using nonsteroidals, because it seems like inflammation is really the crux of it. Now, as was beautifully stated a few minutes ago, we don't want to eliminate inflammation because we need that to survive, to fight infection and do all the other things that inflammation, but we have to control it, and we have to modify it so that it doesn't have all the untoward effects, but the normal inflammation that we need to survive definitely would be there. So, as with all nonsteroidals, this has black box warnings. They're all the same for all nonsteroidals, which is a little unfortunate that the FDA actually does this, because they're such different drugs. They're, all the way from the spectrum of COX-2 to COX-1. They're very, very different drugs, but they all have the same black box warnings. But anyway, the IV meloxicam is indicated for use in adults for the management of moderate to severe pain alone or in combination with non-NSAID analgesics. There is a limitation of use that's stated that's important because it does have a slightly delayed onset of analgesia, usually about 10 to 20 minutes. It should not be used when rapid onset of analgesia is required, or it can be used, but another medication should be available for that patient to deal with the acute pain. Or turn the coin on the other side, or maybe on the edge, and that is perhaps give it preemptively so that you're going to block that pain and inflammation even before it occurs. So there is cardiovascular risk. I think we're all quite aware of this. There's gastrointestinal risk. Again, this is with all NSAIDs, including COX-2s, and they're required to state that. And for being fair and balanced, we do need to pay attention to these. We'll spend a little bit more time on some of these later. Serious cardiovascular thrombotic events, including MIs, stroke, and fatalities certainly can occur, but rarely. This drug is contraindicated in the setting of coronary bypass grafting surgery, and all of them can cause GI issues. I think that that's specific for chronic use and not so much for acute use. Nonetheless, I do want to mention that. So the drug is also contraindicated with patients who obviously have a known hypersensitivity, anaphylactic reactions, and serious skin reactions to any of its components or the actual drug. Also pay attention to those patients with a history of asthma, urticaria, or other allergic type reactions. We'll talk about that a little bit. It's that triad of aspirin allergy, bronchospasm, and nasal polyposis that sometimes can trick us, and all nonsteroidals probably would be wise to be avoided in that rare situation. We talked about bypass, and moderate to severe renal insufficiency patients who are at risk for renal failure due to volume depletion, I think is an important concern. I think that's a concern with any nonsteroidal. It is very much of a concern with ketorolac, as you know, and my surgeons that I work with a lot are very reluctant in patients really with any comorbid conditions. Having said that, let's talk a little bit about pain. This is very, very well known to all of you, but increased risk for postoperative complications if patients have pain early on. After discharge, it can create unanticipated admissions, readmissions, delayed recovery, mobilization, and daily activities. That's the bread and butter of what you all are doing and trying to improve. And the worst part, of course, is that poorly or untreated persistent postoperative pain can transition into chronic pain, and really the most common cause of chronic pain is poorly treated acute pain. So we have a huge role here. And as an anesthesiologist, when I started this actually 41 years ago, believe it or not, I was a puppy then, I'm not a puppy anymore, but we were just trying to get our patients through the operating room. We just wanted to get them to the recovery room. Now when I work with my residents, I say, what can I do to improve not just short-term outcomes, but long-term outcomes? I want to make these patients get through surgery, get through this big stress event, and get through it and do well. Otherwise, why should we do it? Look at the cost. Look at the time spent. Look at the amount of energy spent. And if we have a bad outcome, if the surgeon's a great surgeon, I do great anesthesia, but if we have a PE, MI, or stroke, who on earth are we helping? We're not helping anyone. And so I really am now focused on long-term outcome and what I can do to try to improve those outcomes. And every single thing that I'm doing in the operating room is tied to that. And I think that my care has changed, I think improved, and I keep trying to improve it as we get new opportunities like this medication. Just as a friendly reminder, up to 88% of patients report at least moderate levels of pain postoperatively. This is not good. And this is from some fairly recent data. If you look, I have to use the pointer. If you look at the bottom, TJ Gann, a good friend, came out with a study not too long ago showing similar data to what had been published earlier, which had been published by Jeff Effelbaum 10 years before that, and actually Carol Warfield 10 years even before that, that we really don't do that well. Now, I think that this is a number that we need to still keep in our minds, that even with all the work that we're doing, this is the patient's perception. And it's, again, the patient perception that's so important. That's what gives us good HCAP scores or bad scores if we don't address these. And so the concept of addressing this, and again, not eliminating it, it was so eloquently stated earlier, but setting reasonable expectations, but doing our very best. Looking at pain, this is all very familiar to you. You've got the surgical site of incision up here, creating inflammatory mediators. This is where NSAIDs and local anesthetics work. I do recommend to my surgical colleagues for every single patient that they inject local anesthetic before they make an incision, even if I've done regional, even if we've got great blocks, even if we've got neuraxial and all of the other things, because I believe that every single thing can help. And the injection of local anesthetic into the site, like lidocaine, is really a very, very minimal trespass, if you will. Some surgeons can't because they need to palpate and so forth, and I understand. And then I suggest that they use bupivacaine at the end because it's long-acting. If you have the liposomal, of course, or the other preparations, that's wonderful. But even on top of regional anesthesia, because, as you see, you get the nerve impulse, so you can block it here, but if you start blocking it even here, it doesn't even get here. Then you get all the modulation in the interneurons where NSAIDs, opioids, alpha-2 agonists, ketamine, and SSRIs and other drugs can block that. And then, of course, we've got the upward pathway, the ascending pathway, and in the spinothalamic tract, and then getting up to the brain where we start to see the perception. But then even more importantly, once the brain starts seeing the perception, you get these messages coming back down. Somebody just stabbed me with a knife. I shouldn't be lying there still. I should be fight or flight. I shouldn't be doing that. So these are huge, multiple complex responses, and that's why we need so many different analgesics at all these different levels. This slide doesn't mention it, but there may be a central effect, a COX-2 central effect of NSAIDs. It's not quite clear, but there may be that additional site to help up at this place, and that's where the acetaminophen would work as well. The American Society of Anesthesiologists have guidelines. These came out about 10 years ago. I was involved. Unless contraindicated, patients should receive an around-the-clock regimen of COX-IBs, NSAIDs, and acetaminophen. They say or. I would say and/or, because having studied acetaminophen, it works wonderfully. Any of us who have had kids who get a fever, we know that we alternate the Motrin and the Tylenol and keep their fevers down, and it works wonderfully. Worked wonderfully for with celecoxib and acetaminophen when I had my bunionectomy and had 0 opioids. And went beautifully. I'm walking. Anyway, the drug IV, we didn't have this. The IV meloxicam is available. Let's spend a little bit of time talking about the drug. It preferentially blocks COX-2, as I mentioned. This is from some in vivo studies. The oral product was approved as Mobic. Many of you may remember that, the branded name there, from 2000. For chronic pain, osteoarthritis, rheumatoid arthritis, dosing goes from 7.5 to 15 because it has a large first-pass effect. The Tmax is 5 to 6 hours. So to get a steady state, you need to be taking this for long periods of time, and it won't work right away. So, whereas with the IV drug, since it doesn't have the first pass effect, in doses of 30 milligrams with this nanocrystal technology that was developed to allow it to have solubility, it permits IV administration, immediate availability. Tmax is about 7 minutes, give or take, as I mentioned. Now that's the Tmax. The actual effect on pain is probably about 10 to 15 minutes, so it does take a couple of minutes to work. Looking at COX activity varies depending on the physiologic state. Remember that COX-1 is constitutive. They're constitutive enzymes that are expressed to maintain renal, GI, and platelet function. We need those. They are important. That's the important part of inflammation I was talking about. We don't want to block that like ketorolac, as you'll see. Whereas with COX-2, this is mediated by injury, by surgical incision or trauma. And of course, when we block these effects, we avoid the pain, the inflammation, the fever, and there's some limited homeostatic effects that we'll talk about. So if you look at the COX-1 to COX-2 selectivity, and this has been known actually for a fairly long time, this is, some of the work is in vitro, not all of it is in vivo, but putting this all together, realize that this is a logarithmic curve on the bottom, a logarithmic scale on the bottom. Increasing COX-1 selectivity Very high is ketorolac. So ketorolac is doing all the things we don't want to do, okay? Even aspirin, ibuprofen are there. Diclofenac begins to switch over. Celecoxib and meloxicam are in this region close to the extreme COX-2, like rofecoxib or valdecoxib, both of which I studied extensively, and even a second generation called etoricoxib, none of which are available. But as you go further this way, you get the increased clotting and CV events like MI, stroke, and PE. As you go further this way with long-term use, you get GI effects, but certainly you get the bleeding. So there's got to be a sweet spot. And again, to lump all of these drugs together like the FDA does in terms of a black box seems a little unreasonable, but we're stuck with that, and I respect that. But my point, though, is there's got to be a sweet spot somewhere between these two that actually you can sort of say, wait a minute, you're not going to get the extreme COX-2. These drugs aren't available, as you know, anymore. And you're going to hopefully avoid some of those COX-1. So I would recommend that you think about this, especially in patients who, for one reason or another, cannot take ketorolac. And there's a fairly large group of those. But then again, this drug is approved to be able to be used preoperatively or preemptively, as you'll see from the studies that were done, versus ketorolac, which absolutely cannot be given intra-op. And with regional anesthesia, there's some limitations and so forth. Looking at the pharmacokinetic profile quickly, you'll see that the IV gets a very high blood level quickly within the 7 plus or minus minutes. And you'll see that it lasts because if you go out 24 hours, you have twice the blood concentration that you never even got to with a single PO dose. Granted, this is a smaller dose, but the larger dose is not recommended PO because of, again, the first pass effect. So these are the studies that were performed. 3A for approval, 3A. 3A for the, sorry about that, 3A for the, with orthopedics, you'll see the different kinds of studies that were done. Bunionectomy being a very good pain model. Don't forget the podiatrists and the dentists. My wife is a dentist, so I have to watch what I say here. But they got it right because they do so many outpatient procedures in their clinics and their offices that they had to provide regional anesthesia. Otherwise, the patient wouldn't stay in the chair. They'd run away. And so they got the concept of preemptive analgesia and preempting pain before it occurred, long before we did. We were way, way, way behind. So it's a good model to look at bunionectomies, but here are all the ones done in soft tissues, and we'll spend time on the GI surgeries because there were some very elegant studies, well performed, that were performed for the FDA approval. And then the 3B studies in orthopedic and soft tissue, again with colorectal surgery specifically, that I'll spend a little bit of time on. So going quickly through the bunionectomy, IV meloxicam was administered after a popliteal block that had been placed for the bunionectomy was allowed to wear off, and when the patients complained of pain, they were admitted study drug, the drug versus placebo. You'll see here that at all time points there was significant improvement, and they had backup opioids for pain management for breakthrough pain. There was 31% less pain based on SPID scores. For those of you that are unfamiliar with that, we use those in pain studies all the time. Some pain intensity differences, and a lower number actually is better for SPID scores because it means you're actually doing better. So this was one of the studies, and again, I don't want to spend as much time because I don't think that it has as much relevance, but this one I think does, where at the abdominoplasties, and looking at this cohort of patients with a similar kind of protocol where you'll see that within 3 hours of surgery, they were administered study drug versus placebo, and it kept going actually out to 48 hours, so they got up to 3 doses. At all time points except the first 6 hours, there was a significantly less pain. This is as recorded by a 24-hour SPID score. It's interesting that at that 6 hour, it was not statistically different, but numerically it was still clinically quite different. And so this drug works. It does decrease opioids significantly. These are the kinds of studies that the FDA wants for approval. Looking at major surgery, there were stratification based on renal function. I think this is important with a high risk greater than 65 with GFRs less than the 60 to 89. And you'll see that that high-risk group, we can talk a little bit about that later, and received up to 7 days of treatment, so quite a prolonged period if they were still in the hospital getting this drug Q24H. And the primary objective of this was a safety study looking at safety and tolerability. Quite a large study, by the way. Had about 700 some odd subjects. There were orthopedic and soft tissue, almost evenly divided. You can see the types of surgeries, and actually looked at the safety and tolerability up to 28 days. Here are some of the adverse events that are required to be reported by the FDA for these kinds of studies, which look at incidents of reported events, not prospectively looked at, but retrospectively tabulated, if you will, on your patients and subjects. And you'll see that if you look at the parentheses, which is the percent, these are the absolute numbers, so they can be a little misleading. But you've got about 500 in the study group and about almost 200 there. You'll see that these are really quite not different at all, statistically for sure not different, and even numerically almost the same. Looking at a very important thing for surgeons, so for the surgeons in here, this would be something to really feel good about, is that the surgeons were asked to assess the patient wound healing on a scale of 1 to 10, looking at those subjects who at discharge versus the placebo, and there is no difference whatsoever in wound healing. And I think that's a very important point. The other point is for the orthopedic surgeons to remember that bone healing occurs in 2 ways. When a bone is broken, either when we break our bone or if the surgeon breaks our bone and fixes it for us, the bones heal first by osteoclastic activity, which means that the osteoclasts break up the sharp shards of bone to allow it to heal. That takes 2 weeks. It's been known for about 50 years that NSAIDs as a class do not interfere with osteoclastic activity. So NSAIDs make perfect sense in the first 2 weeks. However, after 2 weeks, then the osteoblastic activity, which allows the bone to heal and form properly, that is interfered with nonsteroidals. So what most of my orthopedic colleagues are doing is backwards. They don't give it for 2 weeks, nonsteroidals, and then give it to them afterwards, and then find out that there's non-union. But I think that these are really important points as we consider the use of preemptive use of nonsteroidals, and specifically ones that are a little bit, that are COX-2 leaning. Looking at adverse effects in these studies, constipation, GGT differences, anemia, not statistically significant, and low numbers. Again, some warnings about nonsteroidals. These are generic to nonsteroidals. Elevations of LFTs have been reported. There can be severe cases of hepatic injury, fulminant hepatitis, liver necrosis. It's rare, but obviously if any of this happens, you need to discontinue the drug. Hypertension, including IV meloxicam, can be caused by nonsteroidals. And worsening pre-existing, we'll talk a little bit about that. Heart failure can be worsened. Post-MI patients, really, you want to look carefully before you use any nonsteroidal, including this one. And again, these are generic to all nonsteroidals. So looking at the phase 3B, which I found very, very edifying, the work that I did, by the way, was on platelet function. So if anyone has questions on that, please ask afterwards, because I don't have that on the slide deck here. But looking at platelet function, because that's something that my surgical colleagues, that's going to be their first question sort of out of their mouth reasonably as to whether or not there are issues there. So put a bookmark in that and we'll deal with that. But let's talk about the 3Bs for a second. Looking at preoperative rather administration, so preemptive use in colorectal surgery and total knees. It was part of an ERAS protocol, very well done, very standard, not different. This one is for the looking at the bowel surgery, and I'll spend a little bit of time here looking at the timelines. patients were consented, and then 90 to 30 minutes prior to surgery, they were given either the IV meloxicam IV or a placebo, gabapentin and acetaminophen. We've talked a lot about their value, and I know gabapentin has now undergone some scrutiny, but I agree with the past speakers that it seems to help in many patients, and if there are no contraindications, it seems to make great sense. The logistics sometimes can be a little difficult with that, getting it on ahead of time enough so that there's, and I know we've got a talk about that coming out using the real pharmacokinetic profiles. Anyway, received IV opioids intra-op, and then for post-op received the drug continuing out to discharge as long as they were there with IV opioids as backup, oral opioids when they were able to tolerate that, and continuing acetaminophen. Primary endpoints were use of opioid analgesia, time to bowel function, and length of stay. And so let's take a look at those results here. With adverse events, it was kind of interesting to see that the IV meloxicam actually had, with patients with one or more event, had fewer numerically in almost all cases issues here. These are not statistically significant, but the one that really came to mind was the ileus, and I think that that's really where the money is, because you're looking, I don't know where my pointer is, but anyway, those are different numbers, and there it is. Thank you. Thanks for getting my, I don't know where it went. Anyway, that's quite it's not significant, but an important difference, and I think that's what the kind of thing that we're looking for to get good pain relief, but not have issues with ileus, obviously, through excessive opioids. Mind you, I'm not saying we need to eliminate opioids. I agree that maybe the pendulum has swung a bit too far, but we certainly want to use opioids only when they're absolutely necessary. When I trained 35 years ago, we were giving opioids to everyone in huge doses, and now we understand that even that first dose of opioids can really cause major changes, both neurophysiologically and probably spinally as well. And so they're already getting predisposed with hypersensitization and all sorts of other issues that we really didn't understand very well. But my point is that with a drug like IV meloxicam and acetaminophen, we can and gabapentin and regional and local anesthesia, we can preempt. We can treat before the pain occurs. If we treat pain, if we treat with opioids before pain occurs, all you get is the adverse events, because there's no pain. And so the time that opioids work well, and this I was never taught, and it's just, is that if we've used every other option on that map that shows all of the pain pathways, both up and down, ascending and descending, if we've used every other option that we possibly can and we're still not there, that's when small doses of opioids really make a difference. Then they really help. And we're not going to get all the opioid-related adverse events. But we have to have done all of the other steps. And once we've done that, and then we use very small doses of opioids, whether they're IV or PO, they work well, and the whole likelihood of abuse later on is significantly decreased. My wife, as a dentist, as I said, showed me a study from the dental literature showing that teens who have molar extractions, who get one dose of opioids, one dose, have a 3 times higher incidence of opioid tolerance and opioid abuse. And I know those are old terms. I'm not using the most updated terms. I apologize. But the point being, that's really just one dose. Just one dose. So what I'm saying really does ring true, I think, in terms of even a small dose of opioids can really cause major, major neurophysiologic change that we're just beginning to understand. So anyway, talking about the study again, going back towards recovery markers, and this is, of course, really important, 59% shorter time for bowel sounds to occur, flatus, 25% shorter time, and a 17% shorter time for bowel movements. And again, and all times this was very statistically significant. I think these are really important. Also, the length of stay, shorter by 1.1 days in the active group and the placebo comparator, saving a day of admission, statistically significant, with everything else the same. Because somebody asked earlier, what if you just take one thing out of this? Is the whole thing gonna collapse? Interesting. Well, if you add this, looking at it again from the other side of the coin, if you add this, then you really do have some value in terms of one day. That's very significant, I'm sure, by the hospital C-suite, the people wearing the suits every day. I like wearing my scrubs, as was said. Also, mean costs are modified. And while this was not statistically significant, I think most people would say that, you know, a 10% decrement in costs is quite important, even if not statistically significant. And again, these are the kinds of things that you can bring to your administrators and your pharmacy teams so that they can begin to understand the value proposition of a drug like this. I'm not sure you're going to get this kind of information or data on ketorolac. I'm not quite sure that it's even going to do that as much because of that COX-1 to COX-2 variability that we saw. Looking at renal toxicity, NSAIDs as a group can cause renal papillary necrosis, renal insufficiency, acute renal failure, and that is quite serious, as you know, and can really increase mortality. We need to watch for that, and there is advice that we not allow patients to get the drug if they're hypovolemic. I try not to have hypovolemic patients. I also try not to have hypervolemic patients, and I know that'll make my surgeons happy. I see a few smiling, and that's also very important. Again, we were not taught that. Don't forget, we had very, very vasodilatory drugs early on. I was there. They were terrible. They were dirty old drugs like ketorolac. Lots of side effects. Their side effects were worse than their effect. And so, thankfully, now we have drugs that are spectacular, dexmedetomidine, propofol, the newer inhalation agents that we have, compared to what I started with, which was very, very basic. And they were terrible vasodilators, so we really struggled with blood pressure. Not that we still don't, but not to the same extent. And we've also understood that the use of vasoconstrictors like norepinephrine and, as was mentioned earlier, and or phenylephrine really makes sense to keep the blood pressure at a safe level and never let it to go low. Because of all the things we can do, or all the bad things that we can do, letting the blood pressure go too low is probably the worst. That probably is the biggest factor in mortality post-op. Intra-op mortality has improved. This was talked about at the most recent American Society of Anesthesiologists meeting. Markedly, we're really doing very well there. We got Institute of Medicine commendation about 20 years ago for the work we've done in patient safety. We really, as a specialty, had done great. Where we are not doing well, and I'll say this again, where we're not doing well is post-op mortality. It's the third leading cause of death. So we really have to think about what we're doing post-op to make sure that patients don't get hypoxic, low blood pressure. And I mean, we can put little blood pressure cuffs on fingers now and Bluetooth them so that we can send messages if there are problems. We have to start thinking that way. If they're desatting, we have to know this and wake them up. I mean, even something giving them a little alert somehow to wake them up so they take a deep breath if they're snoring and apneic or what have you. Anemia is also another one, and that's a whole different story, and that's a whole different talk. But at any rate, anaphylaxis can occur. Meloxicam has been known to cause that, and especially with aspirin-sensitive asthma patients, as I mentioned earlier. Serious skin reactions, Stevens-Johnson syndrome can occur with all of them. It's very rare, thankfully, extremely rare, but it can be fatal. Again, this is most common with chronically used nonsteroidals and very uncommon, thankfully, with the IV use of these medications for short periods of time. And I group them all together, not this one specifically. Drug reactions with eosinophilia and systemic symptoms, hematologic toxicity such as anemia, and fetal toxicity. So for our OB patients, we should avoid its use. at about 30 weeks gestation, up to 30 weeks, and really probably avoid it until the cord is clamped. I like to think that everything I administer to a pregnant woman is going to get to the baby, and the better that I can get that isolated and cord clamped, then of course I can administer anything that I need to. But then warning the mom that it will get in the breast milk, and that she should still express the milk, but not feed it to the baby until the effect of those medications is gone. Talking quickly about the knee, that's a little bit less, I think, interesting perhaps to some in the group here, but similar kind of protocol, administering the drug with the typical preoperative medications, either with or without the IV loxicam. You can see that was given in the perioperative period. They got intraspinal bupivacaine, and they also got bupivacaine infiltrated. So you see doing this infiltration as well as the spinal bupivacaine. And then, again, this is for total knees. And then giving it Q 24 hours. That should read 24 hours, not 2 to 4. Sorry. And then IV opioids, oral opioids. This I did before, sorry, I went backwards. Endpoints were use of opioid analgesia, and secondary endpoints were summed pain intensity and safety and tolerability and length of hospital stay. Here is looking at that, 33% less pain. Independent with assisted ambulation. Interesting, with independent ambulation, it was still very high, 30% less pain, but not statistically significant, but I think clinically quite important, and then statistically significant less pain within the first 24 hours. This is important for getting our patients up and moving around. When they get opioids, they sit around in bed and don't want to move. They don't want to talk to you. They want to go back to sleep. That's not what we want. That's not what the surgeons want. And so this really is an important message, and that's not just true for ortho patients, of course, as we know. Looking at adverse events, and we're almost there. You guys are doing great, and I'll leave some time for questions at the end. But looking at adverse events, this cohort of patients had approximately 150 subjects. So again, look in the parentheses as to the percentages, the nausea, vomiting, and so on and so forth. You'll see that they're essentially not different. The one that caught my eye was the headache. And the hypertension. The patients who got the drug didn't get either of those, and again, not statistically significant, so I don't want to hang too much on that, but I think that's an important marker to show that the patients are more comfortable. And again, of course, as an NSAID, it treats headaches, and patients do get headaches post-op for multiple reasons. And as was said very eloquently before, no pain, and I guess I would add no headache, no patient. So I love that. And then it's not only the patient's headache, as we know. It's the headache kind of goes all the way around. So that's a good thing. Looking at a little bit more granular here, 33% of the subjects experienced less pain through discharge. They were discharged about 4 hours earlier. That didn't meet statistical significance. We can talk about how important that is. The costs were, and this is kind of combining the data. We talked about the non-significant but important cost savings for hospitalization. Post-discharge, the patients required few nursing facility, skilled nursing facility type of issues. As you can see, fewer readmissions, fewer ED visits, and fewer phone calls, and that's where the headache factor comes in, I think, on both sides, and we just certainly don't want our patients to be uncomfortable. Drug interactions very quickly can interact with hemostasis, warfarin, aspirin especially, that's why it's used, but it can interfere with, so any NSAID can do these theoretically. ACE inhibitors, angiotensin blockers, beta blockers, as you can see here, ARBs, diuretics, they may slightly decrease the efficacy of the diuretics, so you need to ensure that those diuretic effects are occurring. And we talked a little bit about pregnancy and infertility. Again, probably not a drug to use if a woman is trying to get pregnant. But again, that's more of a generic comment for NSAIDs per se and less specifically for this drug. So why would we want to use this? Why would we want to change our SOP, our standard operating procedure, from using ketorolac perhaps post-op and finding out that in many cases it's contraindicated versus a drug that almost never would be? So here are some outcomes, and looking really between the phase 3 and 3B outcomes. And on top here, these are different testing systems, as you can see. Basically looking, one of them, the PGA stands for Patient Global Assessment, the BPI Pain Intensity Domain of Brief Pain Inventory, and you can see overall benefit of analgesia with the last one. And you can see that in bunionectomies, the value created was huge. At 24 and 48 hours, significantly more patients reported good to excellent pain control, and you have the numbers there. In the abdominoplasties that we spoke about at 24 hours, again, good to excellent pain control, really improvements. And this goes back to the HCAP scores. This goes back to the perception of how I was treated. Did I get well cared for? They don't really know the patients all the details, but if they felt better, that really is a good thing. People know that they might be uncomfortable after surgery or are very concerned about that. And if we can exceed that expectation, we're going to do really, really well on scoring. Looking at the colorectal, and this is probably the one that has the most bearing here, on post-op day 1, significantly lower for patients receiving this in terms of discomfort and so forth, and it's a lower scale, and the same for the total knees, as you can see there. So I think this is very compelling evidence that this drug, and again, there are no head-to-heads with ketorolac, so I can't, give you anything that isn't there. But at the same time, I don't believe, and this is a personal belief, that if you did these same studies with ketorolac, that you'd get anywhere close with this. I don't think so. So it can be used inpatient, non-opioid. Option aligns with hospital opioid stewardship goals. We've spent most of this meeting talking about that. Once-a-day dosing is very cost-effective, because if you have to give a drug Q6H, there's a huge nursing costs, there are huge pharmacy costs, there's a lot of work. If you have to hang a bag of something or a bottle of something, this is different. You give it once every 24 hours as an IV bolus. That's really kind of special, to be honest with you, as an anesthesiologist. Others don't appreciate the ease of administration, but for us and for nursing, that's huge. Discharge earlier in colorectal and total knee, lower hospital costs, fewer discharge, going to skilled nursing facilities, et cetera. Outpatients, administration of opioids, increased risk of sedation and depression, which you don't want in your recovery room in outpatient surgery settings. It reduces rates of nausea, or the rates of nausea and vomiting, I should say, are similar to placebo, so it doesn't worsen those, which of course is important. Up to 24-hour duration, so you could potentially give a dose right at the beginning of a very short procedure and have that patient go home really quite comfortably and get 24 hours until they can transition over to PO medications, either meloxicam, and I know that transition was talked about by one of the earlier lectures as being a really important point, but transitioning over to PO meloxicam while you still have a blood level would make pharmacokinetic sense. And it's a very good drug, again, because it can be given once in 24 hours. Obviously, celecoxib is good. There may be some insurance issues, as were mentioned with celecoxib, which is a shame because it's a great drug. Fewer post-op phone calls, et cetera, and there is a pass-through status for procedures that are through ASCs, and again, the teams that are here for the company can address those exact details with you for your specific hospital system. I certainly wouldn't pretend to know that, but I think that's an important question that you would want to ask with your pharmacists and your teams if this is something that you feel could have great value in your practice, and you would need to get your pharmacists involved and be able to show them the kind of presentation that I just did, obviously summarizing it a little bit so that it's a little bit more pithy. I don't mean that I've been speaking too long, but I probably have. But anyway, so we get back to where we started, where we have an IV meloxicam, first and only once in 24-hour IV analgesic, demonstrated safety and tolerability. It's COX-2 preferential, as we mentioned, once IV push, and it has some very compelling post-approval data on healthcare utilization, which would really help you with your teams to really create that value and show that this is going to improve outcomes. I have the data here. It's public data, and so you're welcome to share that. So I think with that, I'm going to stop. I'd like to leave some time. I think I've got about 10 minutes. Thank you for your attention, for coming in at lunchtime. And again, I'm delighted to have been invited here. Thanks, everybody. Questions, comments? Not sure if that's a question or a comment. Let me spend a minute then, just 1 minute, and talk about the study that I did, which was with a grant that I got from the prior company that was developing this product. And because the first question that I asked when we had advisory board meetings was, what is the platelet function? Because that's what my surgical colleagues are going to be very concerned about. My regional colleagues that are going to be doing blocks are going to be concerned, can we do the blocks? Is there a risk there? And the good news is that we did an ex vivo study with healthy volunteers actually in Salt Lake City. And the reason I mention that is that I've never seen such excellent volunteer candidates. They did get paid a very small honorarium, but no drugs, no birth control, no vitamins, no alcohol, no smoking. It was unbelievable what sort of great samples that we were able to get. And I say that because all of those things can interfere, as you know, with doing platelet function studies very severely, especially if you went to LA where everyone's taking all sorts of weirdo things. Anyway, local nuts. Anyway, the bottom line is that with PFA, which is a platelet function analyzer made by Siemens, it's been around for about 25 years. A different company used to make the machinery, but it really does very accurate, reproducible platelet function studies with two cuvettes, one with an ADP and one with an epi, and they have slightly different meanings. One is aspirin dependent, and the other one is not aspirin dependent. But looking at those in big picture, comparing it to saline, and we titrated what would be appropriate levels of IV meloxicam versus IV ketorolac versus saline in the same volume so that we wouldn't have a volume effect. We showed very convincingly that the IV meloxicam really has no issues with platelet dysfunction at all, whereas ketorolac had an enormous amount, and nor did saline for that matter. So it was good that our control didn't have any either. So the point being that if you or your surgical colleagues have concerns about that in terms of using it preemptively, I think that I've shown you, and from a number of different angles, the platelet, the wound healing, and bone healing, that it makes sense to consider use of the nonsteroidals early on, probably preemptively if at all you can, to block that inflammation, the bad inflammation, if you will, not the good inflammation, before it occurs. So questions, comments? Yes, thank you very much.
When do you say, oh, I'm not going to use an NSAID in a patient who's diabetic, hypertensive, might have had a TIA, is at high risk? Or when do you say, oh, I'm not going to use a COX-2 selective, I'm going to go for a non-selective or more COX-1 selective, or leave it altogether?
That's a superb question, and thank you so much for raising it. I really appreciate that. Probably my answer is, if I can get it, I would use the selective COX-2 leaning nonsteroidal all the time. The reason being less for those issues and more for the better analgesia. But going back to what you were concerned about with the comorbidities, which are certainly not insignificant, and many of our patients have them, I don't feel uncomfortable really with the IV meloxicam in administering it to those cohort of patients, with the exceptions that I made. In other words, if they're having a CABG surgery, no, because that's not. Oh, by the way, approved for 18 and up. I know the company is trying to work on pediatric indication. We're beginning to work together to pull together protocols. They did get approval, so stay tuned for those of you that are peds, but you may still have some 18-year-olds coming through for scoliosis or what have you, so, but again, stay tuned for that. But to finish the question, which was such a good one, and thanks again for raising it, In terms of the comorbidities, I don't think any that you mentioned really are contraindications specifically to the meloxicam. To ketorolac, on the other hand, I'm really worried about it. It's just, there's so many issues, especially renal, and that's really where I'm concerned. And there's actually one slide, if I can go to it. I'm going to try to find it. Yeah, here it is, mild renal impairment in elderly subjects. Remember I said that we looked at high-risk individuals over 65 with some modest amount of renal impairment, and this is from the phase 1 studies, looking at renal function, and this is healthy adults, and this is the elderly with mild renal impairment. No issues whatsoever. This is QT, but I don't remember if there's another slide here on this is hematocrits, for those of you who are interested. Creatinine changes, yes, here it is. So phase 3, looking at the major surgeries, combining the data of the phase 3s, looking at baseline impairment and then follow-up, it really doesn't seem to have any effect. You can see the comparison between the normal subjects and those defined as age 65 years and over with a mild modification in their, or decrease in their GFR. Anyway, this is going to some more pain intensity. I think that was the one, and here's, yeah. So that was, so to answer your question kind of in a long-winded way, I think that I wouldn't feel uncomfortable. I think in someone who's got severe asthma and an aspirin allergy, I would hold off. Anyone with a known allergy to this specific drug, anyone with really fulminant hepatic issues I would avoid, and you'd avoid acetaminophen there obviously as well. They may not be ideal candidates for the type of surgery we're talking about, but they may be coming to us for surgery nonetheless. And those would really be my limitations. And again, hopefully we can get a pediatric indication, which is not there, so I can't really talk about that because I don't have that information. Whereas with ketorolac, I really have a lot of concerns, and it really stems with that platelet function and relatively poor analgesia. It really isn't helping as much as we think it does based on the COX-1, COX-2 that I showed you. Any other comments, questions? All right, well, I finished with 3 minutes to spare. I think that I really appreciate your attention and look forward to talking with some of you down here if you'd like. Thank you.